did that. Yeah. Yeah, ready.
All right. So today we have a bit of long and many loquats, so I'll try to compact them, but I think you'll follow. And I'll be presenting to you a 33-year-old female who was gravida 2 para 1 living 0 at a GA of 15 weeks. And she was admitted to our hospital with complaints of lower abdominal pain and PV bleed. So she reported to had acute onset of severe cramping lower abdominal pain, which was initially intermittent but later became constant. It was non-radiating, didn't change with posture. It was associated with fresh PV bleed, no clots or tissues. It did stain her underwear, but she denied dysuria, vomiting, constipation, diarrhea, fever, or smelling PV discharge, abdominal trauma, or new abdominal distension. She also denied taking any herbs or new medications beside the supplements that she was given during pregnancy. Hope you can discuss that, David.
Okay, so let's go back to the intro. So this is a 33 years old female, because you said it's going to be a long case. So I'll try think quickly and try to save time, although that is difficult with a case like that. But quite an unusual case for a physician, right? A 33 years old female, gravida 2 para 1 living 0. Okay, para 1 living 0. And so the GA is 15 weeks and she presents with low abdominal pain and PV bleed. So in order to save time, I'll just try and mention whatever comes to. I mean, those things that come to mind reflexively at this point. So she's pregnant at 15 weeks gestational age, and then she presents with low abdominal pain and PV bleed. So the very first thing that I think about is any of the different categories or types of, I'm not sure if that is correct to say types of abortion, but because it could be a threatened abortion, it could be an inevitable abortion, an incomplete abortion, or any of those things. And then one other very close differential is ectopic pregnancy. But so those are quick thoughts for now. So let me see the short HPA in order to see if anything raises a flag. So it's cramping low abdominal pain, initially intermittent, and then it becomes constant, but it's non-radiating, and there is fresh PV discharge. That's what I mean. There is a fresh PV bleed, but there are no clots or tissue. So, well, so the next thing that I will do for this patient is per vaginal exam in order to see if the cervix is open or closed, because we have not seen any clots of tissue yet, and there is ongoing abdominal pain, which was initially intermittent and now becomes constant. So if you find the cervix open, that means we are dealing with an inevitable abortion. But I think I mentioned, so the closest differential apart from all these different kinds of abortion is ectopic pregnancy, but we are going to see about that. But then about any risk factors. So for example, um a urinary tract infection, of course, uh, can be harmful to pregnancy, including early pregnancy. But and any other things that could explain low abdominal pain, like cystitis, and this patient doesn't have any GI symptoms like vomiting, constipation, or diarrhea, no septic symptoms or anything that tells you that there is ongoing inflammation like fever, and there is no PV discharge, which would imply a PID, for example, anything, history of the abdominal trauma, which could lead to, or including inducing an abortion, and then anything that could trigger or that could lead to an abortion, including herbs or any medications that are not compatible with early pregnancy. So my thoughts for now are abortion, and another one is ectopic pregnancy. But I think there are many more. So let's just keep going so we can save time.
Yeah, thank you very much. And I like it. You are so well rounded. This is OBS Ogain. So reviewable system, there was no augmentation, no shortness of breath, and no focal neurological weakness. Past medical history, this patient had 2 myomectomies in the past. First one was 4 years ago, and the second one was 2 years ago. She also had a miscarriage 5 years ago. Family and social history, she's an entrepreneur. She doesn't smoke or drink alcohol. So on exam, she was alert and oriented. She was afebrile. She was not pale, not jaundiced. She didn't have any lymphadenopathy. There was no lower limb edema. Her vitals were within normal limits. Per abdominal exam, the uterus was palpated and it was firm, smooth, but non-tender. The fundus was palpated just above the symphysis pubis. PV exam, her cervix was closed. The gloved fingers were stained with blood. But other systems like the respiratory system, the CVS and neuro were within normal limits. So she did preliminary investigations on admission, like complete blood count, which was normal, and MRDT was negative. Urine analysis showed blood +2, but other findings were normal. She also had an ultrasound, which showed a single viable intrauterine pregnancy at a GA of 15 weeks. That's a lot.
Okay, so a review of systems, I think very important for this 33 years old female who presents with, so as of now, and of course that could be misguided, but at this point, what is in my mind is a threatened abortion or something unrelated to abortion. But so she presents with the threatened abortion, and then there is a history of another abortion 4 years ago. Now, my interest would be to know the gestational age uh, uh, during the last abortion. Because so there are some other things that I'm thinking about. You know, there can be some systemic conditions that present with repeated abortions, especially early pregnancy losses. So, antiphospholipid syndrome is one of those, and there are some others which could be more structural rather than autoimmune diseases. But so review of systems, we do not see anything remarkable that is pointing us in the direction of autoimmunity or connective tissue diseases, as I've thrown in some thought. Because, for example, when you talk of APLS, it can be associated with SLE, and so with SLE, we know that if you are talking of lupus, then there is, especially when you put the systemic issue, or there's skin involvement, there's joint involvement, and many other organ systems can also be involved. So I'm interested to know the GA during the at what point did the last abortion happen. But with regards to the info that we already have, the review of systems is unremarkable. Can we see the next slide? So yeah, there is a history of 2 myomectomies, which makes me think the bleeding, because I'm going back and forth. So we've already seen ultrasound results. There is a viable intrauterine fetus, so that means my differential of ectopic pregnancy is out of question now. And physical examination has revealed a closed cervix, and therefore inevitable abortion or incomplete abortion or anything of that sort out of the window. So if we are talking of abortion, then we should be talking about threatened abortion, because the cervix is closed, uh, and she has bled, and there is some abdominal pain, but the cervix is closed. So this is not inevitable. Maybe we talk about a threatened abortion. And another thing is, of course, if you have large myomas, especially if they are submucosal, they can present with bleeding. So that is another confusing issue. And maybe after learning that this patient has a history of 2 myomectomies in the past, my question would be, what were the presenting symptoms that led to the diagnosis of the myomas, because so for some, especially as I said, if they are submucosal, they can present with heavy menstrual bleeding, and therefore, if this patient, this is early pregnancy, and so if she has large myomas, and of course the ultrasound, maybe if this person just concentrated on the obstetric ultrasound part, but then if there was anything, my expectation again is that if the patient had any other masses, maybe the sonographer would have reported. But then I'm just trying to make sure that I'm not complacent after hearing that there is a single viable intrauterine fetus, the cervix is closed. So just to settle with threatened abortion, I'm trying to think of other things. Maybe the bleeding is unrelated to pregnancy, and it can be because of myomas, but the sonographer doesn't report if they are seeing anything different here. And then uh, anything else? So I think I've already discussed the examination. The cervix is closed, and I think that was a very important piece of information for me here. And systemic examination is unremarkable. So I mentioned other systemic issues that can partly present with reproductive issues like early pregnancy losses, but we do not see any signals yet. So we will see if there is anything else. So at this point, because this seems to be very complex, but my thoughts for now would be if there is no ongoing abdominal pain, and if bleeding is if bleeding arrests, then I would think that we are probably dealing with a threatened abortion, and therefore, of course, gynecologists are the best people for managing this, and I think that is what I would do. I would just refer this patient to a gynecologist unless I pick anything which I haven't yet, and I think as the case unfolds, I'll figure out what is going on, but. I think if I make up my mind that this is a gynecological issue, because it's still early pregnancy, and therefore I think a gynecologist, what a gynecologist would do, thinking like a gynecologist, is maybe bed rest, and I do not even remember correctly at this point, but I think they do give some tocolytics, if that word still makes sense. I think it's tocolytics. So anything that prevents uh, that prevents labor, like salbutamol. Yeah. So I think those would be my thoughts for now. But then, because Joseph did a review of systems, I do not see anything else in other organ systems. So those are my thoughts for now. Anything else that you have, Joseph?
Yeah, very nice. That's a lot of knowledge from the field that maybe you last saw patients in 3 4 years. Yeah, so let's continue. Yeah, so you're right. So they diagnosed certain abortion, and they gave this patient bed rest. I don't remember if I saw tocolytic in their notes. I'm reading from their notes. And the patient was given IV paracetamol, but the pain didn't abate. So she was also given morphine. But 2 days later, the abdominal pain became generalized and she vomited 3 times. And the vomitus was bilious in nature, but non-bloody. She reported not to have had a bowel movement for the past 30 days, but there was no fever. So at that moment, abdominal exam showed the generalized, distended, and tender abdomen. So they sent some few labs. Repeat CBC was also normal. RFT were normal. She had mild hyponatremia of 132 and severe hypokalemia of 2.0. But chloride was normal. The ALTS, TALP were normal, and the TBL was also normal.
Okay. So can I see the next slide? So something that is concerning here is that because if you're talking of a threatened abortion, generally what is supposed to happen or what happens, I mean, generally in real life is that abdominal pain abates, the cervix is closed, and therefore everyone relaxes. That fingers crossed, it doesn't happen again. The patient is given bed rest, and we see what happens. But then for this patient, abdominal pain continues, and then the abdominal pain becomes generalized. She vomits 3 times. The vomitus is bilious but non-bloody, and she doesn't report bowel movements for 3 days. However, there is no fever. Abdominal exam reveals generalized distended and tender abdomen. So my thoughts for now are uh, based on what is very conspicuous is that there is some sort of intestinal obstruction. Because if you talk of abdominal distension, we remember the 6 Fs, and we added the sixth F during uh, our last discussion. I think it was a month back. So we talk of feces flatters, which are a very huge possibility for this patient because she has not moved her bowels for the past 3 days. Another one is a fetus. But so you talk of generalized distension at 3 months or at 15 weeks, as Joseph reported. You expect the fundus to be somewhere. It's basically it's just appearing above the symphysis, starting 12 weeks onwards. It's not even at the level of the umbilicus. So with that, we do not expect a generalized distension of the abdomen. It would be localized below the umbilicus. So we are dealing with generalized distension of the abdomen, and therefore a thought of fetus goes away here. So feces and flatus remains. Another one is fluid. Um, and so what is the other one? Is fat. Well, that would have been reported right from the beginning. And another one is a fetal growth, so like a neoplasm. So because the patient has not moved the bowels for the past 3 days, I'm thinking of feces and flatters. So there is intestinal obstruction here, and there is the abdomen is tender. So is peritonitis happening? Probably. This patient is having peritonitis, or maybe it's although I'm not sure now. I think I have to recall my surgery here, but uh, so intestinal obstruction itself, a tender abdomen, most likely. Okay, something of course that is inflamed, because even when someone has peptic ulcer disease, you palpate and you can elicit tenderness in the epigastric area. So whether this tenderness is just because of the intestinal obstruction that I'm assuming, or whether there is some peritonitis going on, I think we'll discover more. And the vomiting that is happening is probably part of the pathology, that she's having intestinal obstruction. Pressure is building up in the bowels, and you end up with vomiting. So that's what I'm thinking about for now. And the labs, so the CBC is normal. We see severe hypokalemia of 2. I think I will not open this box at this point. If I start to discuss the hypokalemia, because yes, hypokalemia can have hypokalemia can come about due to many issues: redistribution, the potassium moving into the cells. We have not heard anything that is moving potassium into the cells. Of course, you can have GI losses of potassium, which can be a possibility, although my mind is racing now. I do not even remember the number of times he has vomited, but vomiting can lead to hypokalemia, and the mild hyponatremia that we are seeing also. Maybe we can implicate that on the vomiting. And of course, if you have intestinal obstruction and the pressure builds up further, you can end up with movement of fluids and end up with electrolyte abnormality. So I think I'll just settle for that at this point. I do not see any other signals. I'm thinking there is intestinal obstruction going on here. So anything else, Joseph?
Yeah, thank you. So one, I think you should summarize the case for those who join later. And are you doing an X-ray?
Well, so summarizing first, so this is Joseph has been presenting a 33 years old female who is gravida 2 para 1 living 0 at 15 weeks gestation. She presented with PV bleeding and low abdominal pain, which was initially intermittent but later on became constant. So physical examination, the cervix was closed, very important. The fundus was just above the symphysis, uh, and other systemic examination was normal. An ultrasound was done, which reported a single intrauterine viable fetus, and yeah, nothing else was reported from the ultrasound. Initial labs were unremarkable, but then later on, the patient abdominal pain was not relieved by paracetamol. She was given morphine. Seems abdominal pain went on, and later on she reports not moving bowels for 3 days, and she presents with abdominal distension and tenderness on palpation. So doing that was the summary. So doing an X-ray for this patient, uh, that is a tough dilemma for me. Why? Because she's 15 weeks gestation, 15 weeks gestation, and the X-ray, there is radiation involved there. Although, of course, at 15 weeks gestation, we know organogenesis has taken place to a large extent by 12 weeks. So it's a tough call to make, and I think so. This is a limitation that I have. I could just be bold and say, well, I'll do an X-ray, because number one, we need to establish a diagnosis, and it's very risky to miss an intestinal obstruction for this patient, because if we miss it, of course, and if we do not intervene, she will die and and defeat the purpose. So, but on the other hand, we are worried about fetal well-being, and exposing the fetus to radiation. But as I said, uh, organogenesis has already taken place. So I think I'm limited here. So what I would do is, if in the facility there is a radiologist, because I think they are better equipped to deal with these issues. So I think this should be a joint effort. If at this point still I am a physician attending this patient, because under normal circumstances this patient would have been under gynecologist's care a very long time ago. But if I was still seeing this patient, I think uh, joint effort, so between whoever is attending this patient, a gynecologist, and if there is a radiologist in the facility, they would also be called in order to advise whether we can go ahead with doing X-rays, having already discussed the pressing issues that are going on. So I think that is what I would do.
Yeah, that's a nice summary, and I agree with you. So those who are taking care of the patients also thought like that they didn't do an X-ray. It was the clinical acumen was enough to diagnose this patient with intestinal obstruction, as you're saying. The surgeon was consulted, and the patient was prepared for a laparotomy. And G-tube was pressed, and the urethral catheter. She was given plenty of IV fluids, and labs were taken. Vitals at this time were normal except for a respiratory rate which went up to 22. Also, because of hypokalemia, she was given 20 ml equivalent of KCl, and she was taken to the theater. These are interop findings. They found collapsed small bowel, 170 centimeter from the ileocecal junction, with a distended part of the rest of the small bowel. There were extensive adhesions on multiple parts of the small bowel and massive peritoneal exudative fluid contents. She also had a periumbilical hernia and huge myoma with a gravid uterus. So what was done was extensive adhesionolysis and hernia repair. So this patient was reviewed 2 hours post-op, and now her vitals were changed. The blood pressure went up to 152/94, stayed like that, I think, for the 2-3 days that I was involved now from that point. And pulse rate also went up to 110. Respiratory rate was high at 30, but temperature and saturation remained normal. So the control K after surgery was 2.7, still low. She received another KCl, 20 milliequivalent. Control K after like 4 or 5 hours was 2.2. We decided to send magnesium, which came back 1.4, elevated based on our labs normal range, but other labs were within normal limits. So another 20 milliequivalent KCl was given, but control K became 2.4, still low. So this was the case of the gynecologist, which later involved the surgeon. But what I was presenting, I was just reading from the notes, their notes. This is a point where they said we should consult internal medicine to help us. We have been correcting this K. It's unusual to correct this K and still low. And so this is where you come in, David. The knowledge that you showed there was very, very astonishing. But now we come to real internal medicine stuff, and you have to help these guys with this thing.
Well, I'm already exhausted. I'm not sure if my mind will work anymore. But so this patient, and of course, I should say that I talked about intestinal obstruction, and I think that was an omission on my part, because I did not ask myself questions. What was the cause of the intestinal obstruction in this patient? And of course, we could have had some answers earlier on. This patient has a history of myomectomy twice. Although, so this is a gynecologic procedure, but any abdominal procedures could end up with adhesions, and adhesions are risk factors for intestinal obstruction. So, but we leave it there. Now, this patient is so post-op. She presents with hypertension. She presents with tachycardia, tachypnea, and the potassium is persistently low, as well as magnesium is elevated. Well, it's interesting, and I'll tell you up to this point, I've read about magnesium. I have not dealt with magnesium many times, and therefore, when I think about anything that causes hypermagnesemia, I mean the dynamics, because sometimes textbook knowledge is the way you approach a problem. Sometimes this will be textbook knowledge, and therefore the dynamics of magnesium, almost when you are discussing magnesium, you can discuss it almost in a similar way like potassium, but then I won't have any substantial differentials, because so the issues of movement between different compartments. So the hypokalemia, now what is causing this persistent hypokalemia? So I think I started discussing earlier on about the potassium. And so when you are thinking about potassium, so one physician I like listening to has this saying that when you come across hypokalemia, your first question should be, where did the K go? Where did the potassium go? Because potassium balance in the body is about movement between compartments in the body, or movement into a place outside the body. So you are talking about, because when you try to recall your physiology, potassium is predominantly an intracellular cation. while sodium is predominantly an extracellular cation, and therefore more than 90%, I think, I'm not sure if I say 99% of potassium is intracellular, if I'll be correct, but at least more than 90% of potassium is intracellular. And so anything that will disturb, and the potassium balance, at least in the plasma, is tightly regulated by a number of mechanisms, including the sodium potassium pumps that we know. And another issue is you also have movement across across a gradient. You have some transporters, and then the kidney. The kidney is also primarily responsible for controlling, because most of the potassium that you will take in your meal will be excreted, and more than 90% of that goes out through the kidneys in the urine, while the remaining is through the GI and some other mechanisms. So when we discuss hypokalemia now, we should ask ourselves, is there something that causes the potassium to move into the cells? Because that is one mechanism. Where did potassium go? So potassium moving into the cells, and when we talk about movement of potassium into the cells, you talk of things like beta agonists. We use salbutamol and insulin, of course, in order to move potassium into cells. So those are some of the things that will move potassium into cells, and this patient did not use any beta agonists. We are not aware of any insulin use, and uh, no other medications. I mean, apart from paracetamol that was given, uh, and then morphine. So I do not see any medication that is moving potassium into cells. So another thing will be GI loss of potassium, and so here is the issue. Even if someone vomits, movement, of course, so other things can be upper GI losses or lower GI losses. That is through vomiting, through gastric suctioning, or through diarrhea. Those are things that can lead to GI loss of potassium. But then, even when someone vomits, what leads to the hypokalemia is not the vomiting itself, but it's the acid-base abnormalities that are created by vomiting. Because when you vomit, you lose acidic fluid, and when you lose acidic fluid, so effectively it's like you're having a metabolic alkalosis, and the way that is taken care of is by excreting more bicarbonate by the kidneys. And when you do that, you increase the negative potential in the collecting ducts, and you end up excreting more potassium. So the mechanism in vomiting is mostly renal loss again. Yeah, so the vomiting, the intestinal obstruction, of course, all these things could lead to GI loss of potassium. But the potassium being persistently low, and of course, we should remember, I talked about this earlier, the labs that were presented. Um, the potassium was low right from the beginning, and I shied away from opening that box because I wanted to see where the case was going. So I think this is the point to discuss it now. So the other thing is renal loss of potassium. When you talk of renal loss of potassium, you can talk about your diuretics. You can talk about anything that leads to. So I talked about the acid-base abnormalities, diuretics, but then there's something else now, and I've seen people, I've seen a number of people in the chat talking about this. Of course, something raises a question here. So I think the answer is in the vitals and the labs. So the patient is post-surgery. It's not common to see hypertension and tachycardia at the same time. It's not common because you would say if we are seeing tachycardia and tachypnea, maybe during surgery, this patient lost a lot of blood and therefore they are volume low. And if they are volume low, you'd expect the blood pressure either to be normalized by the tachycardia or to be slightly low with the narrowing pulse pressure. and then you see the tachycardia as a response, sympathetic overdrive. Yeah, so we do not expect blood pressure and pulse rate to go in the same direction in most circumstances, except you have a number of conditions that will cause that. So, for example, someone with hyperthyroidism, you'll see that. So, you are talking more of endocrine issues like hyperthyroidism, like pheochromocytoma, for example. So, things like those. Now, when we combine now, because if this patient was volume low, I would actually not expect them to be hypertensive. So I'm not going to discuss volume loss either through the GI, because when someone has intestinal obstruction, they lose a lot of fluid. Uh, but so because there is hypertension, I'm not going to talk about fluid loss, whether blood or fluid, maybe through the intestinal obstruction. So I'm thinking, what explains hypertension and hypokalemia at the same time? And of course, a quick answer that we have is hyperaldosteronism. That is what explains it. Now, a textbook presentation, we would expect to see, because aldosterone is meant to conserve sodium, and therefore the sodium can either be normal or high, but the potassium will be low and the blood pressure will be elevated. So I'm thinking something that explains the vitals and the persistent uh, hypokalemia. I think it's hyperaldosteronism. Now, what kind of hyperaldosteronism, whether it's primary or whether it's secondary, I do not yet have an answer to that question. Now, I think um, if we were at a facility where we can do, where we have plenty of resources, one quick clue would be urinary potassium, because if we take our urine and we measure the potassium levels, and then we see that the potassium levels in the urine are high, we know that there is increased renal loss of potassium, and a number of issues can explain that. Of course, not hyperaldosteronism itself, but others are likely. This patient is not on any diuretics, and I have not seen any medications that can explain that. So I think those are my thoughts for now, and uh, let's see what happens. So I'm thinking of hyperaldosteronism, although which one now? Because I do not know what kind of a relationship between pregnancy and any kinds of hyperaldosteronism. So I think I'll just put a blanket out there. And the sad thing is, I do not have other differentials, and this is very dangerous, because if I turn out to be wrong, then I'm wrong. But I think because the diagnostic process is an iterative process, if I have the facilities, I think I'll try to confirm the diagnosis of hyperaldosteronism. And if I fail, then I'll have to sit and think what else explains this presentation. So those are my thoughts, Joseph.
Yeah, very nice. So as I said, it wasn't my case. I was consulted. So I also suggested, like you, that we should have other labs. And we also suggested the Aldo, but it wasn't available at our hospital. Said maybe we can get it from outside, but we started with what we can have at our hospital, and we sent the thyroid function test. The TSH was normal at 1.39. The T4, total T4 was 300, elevated, and the total T3 was 9.2, also elevated. Does this make anything to what you're thinking?
Well, so the TSH is within normal limits. Yeah, because the range that I'm seeing there is 1.3 to 4.2. So TSH is within normal limits.
Yes, it is
But
normal.
T4 and T3 are both elevated. Well, so and yeah, that's what I said. That it's dangerous to just have one diagnosis, because you turn out to be wrong. And at some point, I mentioned hyperthyroidism, but then of course, even up to this point, I think because so normally what you expect is if we are talking of overt hyperthyroidism, then with this much elevated T4 and T3, you would expect low TSH. But then if we are discussing hyperthyroidism, then I think this is what would be called subclinical hyperthyroidism, because you have a normal TSH. But then I have questions. I think with regards to the vitals, hyperthyroidism would partly explain things like the tachycardia, and so for hypertension, it's mainly diastolic hypertension for hyperthyroidism, although let's just say not try to be very precise, because that can mislead you a lot. So hypertension can also be explained by hyperthyroidism. But then about potassium, and of course another thing that I want us to discuss is, you know, uh, pregnancy is a tricky state, because you have physiological changes. You have physiological changes that that will lead to some alterations. For example, one of the things that I want to talk about is about binding proteins, because you know, even when we discuss about thyroid hormones, we talk about total T4 T3, but we also talk about free T4 T3. Now I think that's another gap that I would need to fill. I would need to go and read that in pregnancy, which would be more reliable in order to make a diagnosis of hyperthyroidism. Is it the total T4 T3, or is it the free one? Because there is a change in fluid composition as well as some proteins, and therefore sometimes the measurements that we use in people who are not uh, who are not um, who are not pregnant, I think they some labs can mislead us sometimes. So I think that is a reservation that I have here. And another one is, would hyperthyroidism explain the hypokalemia? So this is where my memory gets hazy, because I've read about many causes of hypokalemia, and some hormones are also involved. I do not remember thyroid to be one of those. So I think I'm still sticking with I think I'm still sticking with primary, I mean hyperaldosteronism. As I said, I think I'm not in a position to commit. But then hyperthyroidism with the vitals, I think it does explain. But with the hypokalemia, I'm not sure, and therefore I think this is where I would need to open my books. So I keep it as a differential, but then to go and read more about it, because with I mean, with the current knowledge that I have, I think I'm limited to confidently make a diagnosis of hyperthyroidism, explaining the vitals as well as the hypokalemia, which of course I'm having a more difficult time, and of course considering the reservations about whether the total T4 T3 will be reliable in pregnancy.
Yeah, it's, I also got those stumbles as you're doing, and you know we're not used to care with these patients. I see Antimon's comment here. Yes, there was, I forgot to present it, but the I say HCG. I thought it's ECG. The ECG was also normal, but so let's see. Um, so as you're saying, we have a problem here that we should define before we arrive at the diagnosis of this case. And I'll tell you before, I didn't get the diagnosis right in this case. You'll see what happened. So we have a post-op persistent hypokalemia despite multiple corrections, and we all agree this is not likely due to vomiting alone, secondary to intestinal obstruction. There has to be an underlying cause, and the question is, what is it? And also there was new post-op elevated blood pressures that needs an explanation. So we from the internal medicine, when consulted, we considered hypothyroidism as a DDX. That's why we ordered the thyroid function test. But the results, we dismissed them as physiologic. changes in pregnancy and not true hyperthyroidism because of the normal TSH. As you all remember, if you're reading hyperthyroidism, the algorithm says send TSH, and if it's normal, stop there. It's not hyperthyroidism. So that when I saw the results, I said TSH is normal, no matter what. T34 will be high. This is not hyperthyroidism. And I advise them to order other labs outside of the hospital, including Aldo, as you're saying, everyone. But the obstetrician who was caring for the patient was really convinced that this was true hyperthyroidism, and he went on and treated because she was her patient. She was his patient. So I lost this patient to follow up at this point, and the guy is more experienced to caring this patient than I. So I left and I lost this patient. Months later, I came to accidentally saw the patients and the notes, and I learned a lot from this case. So I realized the guy repeated the TSH after months, and it was less than 0.1, very, very low. And also, he also sent the TSH binding immunoglobulin outside the hospital, came very high, 25. But I learned that, unfortunately, this patient had a miscarriage. And when I saw this patient later, she had graves of thermoplasty. She had the exophthalmos, the eyes were out. And she also told me later that her father and her sister, they both have hyperthyroidism. If you read the the genetics involved in graves, it's like 40%. So it was true she had graves. So the first diagnosis in this case was grave disease. That I missed, and I learned a lot as I'll present here. So nicely, David, very nicely discussed. The approach of hypokalemia is that's what also I have. This is the schema I made. I read from, I think it was NEJM case, and I recorded it here. Yes, it's so hard to have reduced intake of hypokalemia because a lot of food that you're taking, they have potassium, unless you have very rare stuff like starvation, you are an alcoholic, or you have anorexia nervosa, you can have hypokalemia from reduced intake. So mostly it will be from an increased loss, and the loss can come from 3 places. One is transcellular shift, as David you're saying. And yes, I knew insulin and salbutamol, but turns out there is a lot of other things, as you're seeing in my list here. So you can see there is meds like insulin, salbutamol. There's theophylline. There is leukemic crisis, refeeding syndrome, hypothermia, syndrome called Anderson-Tawil syndrome that I don't even know what it is, and there is thyrotoxic periodic paralysis, thyroid stuff. So here it is. And then you have familial hypokalemic periodic paralysis. You can have also loss from other areas like GI, vomiting, diarrhea, and renal. So the renal is the most important, I think, in internal medicine. Most of the cases of hypokalemia you will see will be from the renal loss. And the renal, you can arrive at the diagnosis of the renal loss by considering 2 important things. One, the blood pressure. The other is the pH, if you can do the EBG. So if you have hypokalemia and hypertension, as you see in this patient, you can consider stuff like hyperaldosteronism, mineralocorticoid excess, renal artery stenosis, Cushing syndrome, Leidos syndrome, or congenital adrenal hyperplasia. But if the blood pressure is normal, you can have other stuff like renal tubular acidosis, hypomagnesemia. This patient had hypermagnesemia, not hypomagnesemia. Bartter syndrome, Gitzelman, and the use of diuretics. Again, you can do the same on the pH. If the pH is acidotic, RTA, if it's normal, hypomag, but the rest will have most will have an alkalotic pH. We didn't have the ABG at that moment, but from the transcellular shift, we could explain that her hypokalemia was from the hyperthyroidism, from the graves. Now, so many questions comes up. The way hyperthyroidism causes hypokalemia, the thyroid hormone causes increased sodium potassium ATPase activity, but also it increases tissue responsiveness to beta adrenergic stimulation. Both these two, they drive potassium into the cells, causing hypokalemia and or generalized muscle weakness, which is called thyrotoxic periodic paralysis. Now, looking back at the patient, I asked myself, did this patient had muscle weakness at that moment? Because that would have been very easy for me. But I realized I couldn't do it. I know I was standing at the bedside and I was saying this thing. I didn't even touch the patient because I was consulted. The patient was given strict bed rest. How would you know that they have muscle weakness? It would be very hard. And then, to be honest, the notice of the guy, even me, we didn't examine this patient neurologically, to be honest. So we couldn't tell if the patient had neuro weakness at that moment. But the weakness of thyrotoxic periodic paralysis is more proximal lower limb than upper limb. So you have to have someone who is walking who will tell you, I feel weak, because, proximal lower limb, you have to walk, you can't step on, you can't walk on the steps and stuff like that. But it was so hard for us. So up today, I don't know if the patient had the thing, this thyrotoxic periodic paralysis. But even if it wasn't there, you can have hyperthyroidism causing hypokalemia even without the frank paralysis. Although the literature says this is less common than having thyrotoxic periodic paralysis with hypokalemia. Other things I also learned from the OBS and from reading is the relationship between hyperthyroidism and pregnancy. I realized the diagnosis of hyperthyroidism in pregnancy presents some unique challenges. So the body changes in ways to meet the increased metabolic demands during pregnancy. So T3 and T4 goes up. So they say it can go up to 1.5 times the upper limit of normal. If I knew this information, this patient had gone above this. So it was more than what is expected, even if for physiologic change. But another thing, there is an importance to send the free T4, free T3 than the total that we did here. It's unfortunate we didn't have this at our lab. We had the total. So the free T4, free T3, don't do this. Don't follow this physiologic demand to go up. And again, the elevated beta HCG can also cause some clinical really overt hyperthyroidism, because the beta HCG structurally is similar to TSH. And another question which was hounding me was, why was the TSH normal and then severely low after a few weeks? And two explanations I came up with. One is that maybe this grave disease of this woman was in evolution after the surgery and critical illness, and then we are seeing it from normal to transition. And it is well recorded that in this situation, you will have T3, T4 rising, and then TSH catches up later on. So this is highly likely what happened, because I believed our lab, it's the lab that I used also to diagnose other thyroid diseases, and it's the lab also which repeated the TSH later and came less than 0.1. But there is another thing, probably is the critical illness effect. It is known that acute illness blunts TSH secretion, which alters peripheral T4, T3 conversion, causing T4 to go up. So I learned a lot from this case that I didn't get right until I looked later and looked back and realized, first of all, Guy is more experienced than me managing hyperthyroidism in pregnancy, but again, refreshing my approach to hypokalemia. So what do you think, David?
Mind blowing, and because if Joseph, you've some CPC cases in the New England Journal of Medicine, I believe you've come across a case of a male who was presenting with on and off muscle weakness, and when I saw that case and low potassium, I mean, even before reading case resolution and seeing the discussant's diagnosis, I made the diagnosis of hyperthyroid. So that one was because there are two kinds of periodic paralysis. So there's familial and then there's hyperthyroid. So I've never come across a case of hyperthyroid periodic paralysis, or even familial, but I've read about them and theoretically I've made the diagnosis. And so this is what intrigues me more about medicine, that sometimes you so unless, and this is the value of problem based learning, because sometimes you read something from a textbook or from any resource and you actually feel like you understand it, but then what about application? When it comes to application, because I've read about it and I think a number of times maybe I've come across cases and made a diagnosis on paper sometimes, but then telling it to this patient was I mean I it completely evaded my thinking, that hyperthyroidism explaining hypokalemia, uh, probably partly because of the issue that what we expect is, because even hyperthyroid periodic paralysis is, as the name suggests, periodic, so it's on and off. So there are times when this patient is normal, and then sometimes they prevent, and especially when they are under stress, they present with muscle weakness up to a point it's like they are paralyzed. And during those periods when you check the potassium levels, they are low. So I'm not sure if that's partly the reason why I couldn't come across it, but it's been a lot of learning. As I said earlier, I think it was very dangerous to just go with one diagnosis, that is hyperaldosteronism based on the hypertension and the hypokalemia, because there were these other vitals that were suggestive, as I was talking about sympathetic overdrive, and one of the things that I mentioned was hyperthyroidism. So again, reminds us that medicine humbles us every single time, because uh, there are times when you'll get it right, there are times when you'll get it wrong, and in order to consolidate the knowledge to become wisdom, you need real life application. So I think after this one, everyone who has listened to the case, if you come across this, it will be hard to miss the diagnosis, as compared to someone who has just read from a book. Application may be a little trickier for them than for us who have been exposed to this case, although on a second-hand basis, because Joseph saw the case, he has shared it with us, and that has added wisdom. So next time we come across a case like this, we'll be better equipped to make a diagnosis. So thank you very much, Joseph, for the case. I think it was intellectually challenging and refreshing at the same time, because I think I had to recall things that I've dealt with many years ago. Thank you very much.
Yeah, thank you, and thank you everyone who was involved in the chat. It was on fire. If do we have anything from anyone before we close? Yeah, so if there is nothing, I think I should wish you a good night.
Good night. See you next weekend.